What's going on, you guys? It's your boy Tochi. Welcome back to the channel and welcome back to the doctor experience. In this video, I'm going to be sharing my experience in a hospice and palliative care fellowship so far. It is officially the end of my second week. It's Saturday, so I'm still on call right now for any palliative care issue for a patient we're already following. But I still wanted to give you guys my experience thus far for those of you guys that are interested in the field of hospice and palliative medicine, or if you guys are just kind of interested to hear what it's like to actually be a doctor in this field. So this is my second week. The overall experience so far compared to the first week has been pretty good so far. The first week I had a geriatrics fellow following me, so she was kind of able to help me kind of integrate into the team, show me how the EMR system works for documenting and actually checking up charts, writing notes, things of that nature, and then also just how the workflow actually worked. Usually Mondays is our pretty busy day because we not only have the inpatient patients, but we also have our clinic in the afternoon as well. So we try to see as many patients that we can in the morning. That way we don't get too disturbed in the afternoon when we're actually in our clinic where we can't really go and see any new inpatient consults, and they'll probably just get deferred to the next day. So the Monday that I just came from for clinic was pretty good. I had maybe 4 to 5 patients. One of them was a no-show, one of them was in person, and then 2 of them were video calls, and then the other one was a phone call. And those ones were pretty good. They were mostly follow-up patients, so I was able to kind of just, see how their symptoms are doing. One of the big things I'm doing in clinic, specifically that came up a lot this week, was whether a person was hospice eligible. And for those of you guys that aren't familiar with hospice, there's a pretty big misconception between hospice and palliative care. Palliative care is like the overall umbrella of the field, and then hospice is kind of like a mini section of care and palliative care. Usually people that go into hospice are in their, 6 months at the end of their life. So they usually go in there to allow their illness, whether it's malignancy, whether it's cancer, whether it's some sort of end-stage organ failure, and they allow that to naturally play out to the end of their life. And during that time, we are mostly doing things to keep them comfortable, whether it's symptom management, whether it's interdisciplinary care with their actually family members, and then planning for bereavement for when they do eventually pass. So a lot of times the symptoms that they're kind of, taken care of are either pain, shortness of breath, anxiety, nausea, vomiting, constipation. We try to make sure all of those distressing symptoms that they're actually feeling are not something that they're going through. So whether it's, adding morphine, adding some laxatives, adding any of these anxiety medications, pain medications, they are mostly trying to figure that out and, keep that at bay. That way, when they are passing and ending their life, they're not going through, any suffering when they're passing. So that's a big thing that I had to do in my clinic, was whether or not someone was actually eligible for hospice. So over time, when people are put into our clinic, if they're nearing the end of their life, there's a couple of things that we're tracking. We can talk about, let's say, dementia or like frailty. So usually people that have dementia, as they're getting closer and closer to the end of their life, we're tracking whether or not they're eating properly, if they're losing a bunch of weight, if they're not able to do their normal activities of daily living. And if that starts tapering off a lot, like they're not eating anymore on their own, they're not, doing their activities of daily living anymore, if they're losing a lot of weight, we try to enroll them in hospice to give them as much relief as they can. Another thing as well would be like, malignancy and their pain and their cancer pain. So a lot of the times as that cancer is slowly progressing, then oftentimes we want to make sure that their pain is controlled, especially for those of you guys that have, metastatic cancer and they have, like, say, cancer that goes to their back and their bones, and that causes a lot of pain. So making sure that they're on a PCA or some sort of like morphine drip or, morphine medications to control that pain. We are doing that a lot of the times to make sure that they have a comfortable, existence before they pass away. So the patient that I was actually tracking didn't quite qualify for hospice. He is kind of like at an end stage for, I believe it was heart failure, but he was still able to kind of get around, not having shortness of breath, like at rest, and wasn't really having any distressing symptoms. So over time, we kind of just track that in every single documentation note. And if they do start declining, we kind of have a case to convince the hospice agencies and insurances that they actually can go into hospice and they can actually get paid for that end of life care. So that's something that I was actually kind of dealing with in the clinic. And I had maybe one patient that also was kind of enrolling in hospice. He also was a heart failure patient. And the biggest thing for him is that he didn't have like complete heart failure, but he did have a valve that was, normally valves should be opening and closing, but his was just wide open. And that can cause issues such as like, heart failure exacerbations where fluid starts building up in their lungs or any part of like their body. And that can cause a lot of distress for them. So we actually got to enroll him in hospice, and now we're trying to work with his nursing home and enroll him in hospice at the same time so he can get that covered care. So that was pretty interesting. I'm still not the best with it because there's a lot of like, specific medical codes and specific criteria. And it's the whole reason why I'm in fellowship, and something that I'll be learning along the way. So along the way, I'll be kind of picking up on these little small things that I should be asking during my interviews, asking during my patient encounters to kind of make sure that they actually qualify for hospice and we don't have any issues when running into like insurances. So that was something that I was like pretty cool to actually learn, because that's not really something that I focused in on when I was in internal medicine residency. It was mostly just like, oh, we'll just consult palliative care for, goals of care or pain management or, kind of bereavement or support. But the actual hospice criteria aren't things that we haven't really learned or really taught during internal medicine residency. So it's something that's been pretty cool to learn along the way. Another thing that I dealt with this week, I actually ran another family meeting in my last week of fellowship. On, I think it was like Thursday or Friday, I ran a family meeting in the ICU. And again, I ran another family meeting in the ICU this week. And it's tough because when you are dealing with family meetings, the dynamics can really make or break the way that you actually run it. And you have to really be very keen to responding to emotions, letting people, speak and not cutting them off. And oftentimes when you are dealing with people that are in their end times, it's hard to, hear those things, but it's something that we need to hear because you need to understand frustrations people are going through, the sadness people are going through, because it's not until you hear those things that you can actually address and try to help. Because if you're going in there trying to, complete a certain agenda, or like, oh, I need to make this person DNR, DNI, I don't think that giving them chest compressions in their life is going to be beneficial for them. You're not really going to be going in there actually hearing what they have to say for you. So a lot of times going into these family meetings, the biggest things that I do is, set the stage, introduce ourselves, let them know like, hey, we're meeting so-and-so, we're here to talk about this, but let's go ahead and introduce everybody, make sure everybody is actually named. And I tend to write down their names. That way I can actually call on their names and say like, hey, like Mark or Nancy, like I see you're feeling this. I see that you're, a little confused when I said this statement. And actually using names in a family meeting is something crucial that I found was very helpful in terms of like allowing it to feel more natural and not, feeling so disjointed. And oftentimes you have to do what we call a pre-huddle. And what we do with that is that I meet with the palliative care attending, myself, and then whatever team that is holding over the main primary patient. So whether it's the ICU, whether it's like one of the medicine teams, one of the surgeons teams. And the main point of these pre-huddles is that we meet with them to get on the same page. That way we're not going into the meeting having different agendas and going in there with mixed messaging, because that'll really confuse the patients, their family members, and will really make for a really bad family meeting. So I will go in there. I usually lead out the family meetings in palliative care. And I have like, whether it's an ICU doctor or, a medicine doctor to actually give them medical updates. And I'm there to kind of steer the conversation, make sure that everybody is being heard, and then giving strong recommendations or recommendations from the medical team and seeing how they respond to that. And oftentimes when you go into these meetings, it's a very big misconception that you should be getting something out of those meetings right away. A lot of the times it's conveying information, allowing them to chew on that information. And you can always put a pin in those conversations and come back to them later. Like, hey, like, we think that this is what's best for the patient based off of everything that they've gone through in the hospital. So we want to recommend this for you. So usually if a patient can't, consent for themselves or advocate for themselves, then usually we go to what we call a first surrogate decision maker or a medical power of attorney. And say if like someone's sedated or in a coma, then they are the one that's appointed to actually make those decisions. And for those of you guys that are in medicine or not in medicine, I would recommend for you guys to, with your families, with your loved ones, figure out who is going to be that main point of contact and make that, a legal thing. Because if someone goes through a catastrophic medical event and no one's really identified, no one's really discussed these priorities and medical wishes, then it makes for a really stressful situation for the families when the patient actually can't talk for themselves. So that's something that I've found has been very beneficial, given that I'm in the VA and a lot of our patients are older. A lot of times they already have like a surrogate decision maker, and I haven't ran into a patient that hasn't had one yet. So that is something that I would say for you guys that has been pretty beneficial. And for the family meetings, this is something that's not only done by palliative care. Ideally in a perfect world, everybody would know how to run a family meeting. But a lot of times, because of how many patients you're seeing, how busy it gets, a lot of times you don't have the time to perfect those skills of running a family meeting. And a lot of times it gets put onto the palliative care team, so me. So that is something that, I would say if you guys are medical students, try to read over, how do I run a family meeting? How do I, make sure I go in there with the specific, script of how to follow and talk to the patients and talk to the family members. That's something that I would say would be very beneficial for you in the long run, and not just relying on palliative care, but will aid you in your experience and help you with your relationships with your patients. So overall, the experience in my second week was pretty good. I would say that going into my third week, well, next week I'm going on vacation, but going into my last week of the VA, my fourth week of fellowship, I would say that I want to take a little bit more of a higher role. I try to get a little bit more feedback from my attendings week to week to week, so I can see how I'm progressing and track my progress. And I think in my last week of my fellowship at the VA for this month block, I want to see if I can control the whole team and see every single patient on the list. And whether it's running family meetings, communicating with the teams, I want to be the main point of contact and allow my attending to kind of take a little bit more of a back seat, so she can evaluate me and see how I'm doing running the entire team, because eventually in less than a year, I'm going to be running my own palliative care team. So I want to get as much mentorship from those attendings from, a firsthand experience. And the other thing that I would say for my last week at the VA this month is that I also want to see if I can run, usually Tuesday mornings, we have these palliative care meetings with, not only our site at the VA, but also other sites as well, other palliative care clinics that are connected with our VA. So usually we'll talk about, the patients that are on our list, difficult patients that we're dealing with, not only at our site, but the other sites. And then also talk about bereavement purposes. So any patient that has passed away, we usually have cards, we write it to the families. And then if there is any specific, thing that you want to get off our chest, because, dealing with what we're dealing with in our field, we're dealing with a lot of patients that are, expressing a lot of their grief, expressing a lot of their sadness, expressing a lot of their stress, expressing, how they're feeling with their loved ones that are passing away. And oftentimes, the more and more you experience that, the more you take on, but you're not really realizing it. So we really make it a point in those meetings to see if we can actually talk about and debrief about the patients that we are dealing with, and seeing if there's anything that we were struggling with, and a lot of times people are dealing with the same things, but aren't really expressing that. So it's nice to have that forum there for us to kind of discuss what was actually going on. So, I really want to run that meeting as well and see if I can kind of get into that mode and mindset. So hopefully I progress even further, and it's something that I'm really looking forward to for the rest of this rotation here on my fellowship. So I'm going on vacation next week. It'll be nice to have a nice little break. I think my last vacation was it January? Yeah, I think it was January. So it's been a little bit of a minute. I went to Cabo at that time. I'll be going to Cancun this time. So it's going to be a lot of fun. But overall, I hope you guys enjoyed this video. I just wanted to share with you guys my experience, my second week in fellowship. I have a long way to go. And I believe when I get back from my vacation, we'll be having our didactics, our, wellness sessions, our journal club. So I'll update you guys on how those things go as well. So I will see you guys later. If you guys enjoyed this video, like the video, leave a comment down below on anything hospice or palliative care related. It's something that I'm learning, and I look forward to sharing with you guys, and we'll have a nice time. So I'll see you guys later. Peace. Have a nice day.